Hi, I'm Judd Gash. I'm a professor of radiology at the University of Tennessee here in Knoxville. And this is a recording of our one of our GU noon conferences, originally done on May 3rd, 2017. I'll just start with an unknown. We did a couple of unknowns at the start of usually a lot of conferences, but we'll just take one here, and I'll take it, obviously, without resonance. But this is a 37-year-old with right flank pain who presents to the emergency room. KUB and a non-contrast CT are obtained, and the KUB demonstrates multiple calcifications projecting over the area of the right kidney. Some of the calcifications are rounded, but the vast majority of them appear to be somewhat linear in configuration. There's no obvious calcifications on the left. The CT again demonstrates multiple calcifications, some of which are punctate, and more of those are linear. And if we take a closer look at both the X-ray as well as the CT, we can see that although some of the calcifications are clearly within the collecting system, many of which are within the medullary pyramids. CT also, as well as the KUB, demonstrated no calcifications on the left, and also that the right kidney was larger than the left. And these findings are quite consistent with a medullary nephrocalcinosis, but more specifically medullary sponge kidney. Medullary sponge kidney is a condition of abnormal dilatation of the medullary collecting ducts. That dilatation results in urinary stasis. Anything that results in urinary stasis creates a situation of potential stone formation. And in this case, there are multiple stones within the medullary pyramids, creating that linear configuration that is essentially a nice cast representing those abnormally dilated collecting ducts. As in most cases of medullary nephrocalcinosis, some of these calcifications then spread into the collecting system, creating nephrolithiasis. Of the differential for nephrocalcinosis or medullary nephrocalcinosis specifically, there are three general categories, including medullary sponge kidney, probably the most common, along with renal tubular acidosis and thirdly, conditions of hypercalcemic states, including hyperparathyroidism. Medullary sponge kidney, unlike the other two broad categories, is one in which the underlying pathology is anatomic, and that anatomic aberration can be asymmetric between kidneys, or as in this case, unilateral, or even within only a portion of one kidney. The other conditions tend to be metabolic and generalized, resulting in medullary nephrocalcinosis that affects both kidneys generally. Medullary sponge kidney also is known to increase the size of a kidney, thus the somewhat enlarged right kidney. So in total, a case of unilateral medullary nephrocalcinosis and nephrolithiasis with calcifications of a linear appearance, all of which is quite typical of medullary sponge kidney. So what we're going to talk about, and what was talked about in noon conference today, was ureteral stents, and specifically evaluation of ureteral stents for the diagnostic radiologist, and that's as opposed to the interventional radiologist, somewhat completely different perspective. I want to give a recognition. A lot of the content of this lecture, particularly the complications, are from this great article by Ray Dyer and Ron Zagoria and the folks from Wake Forest. Typical ureteral stent. Spend the next 5 or 7 minutes or so talking about sort of the typical or normal ureteral stent, why it's placed and how it's placed, and what it should look like when it's in its expected position, and then what are some of the common clinical symptoms, even in an uncomplicated ureteral stent. Typical indications for ureteral stent placement are basically two, and that's obstruction of relief of obstruction, ureteral obstruction, or an adjunct to stone therapy. So you'll see stents placed when there are ureteral stents and or lithotripsy is being planned for nephrolithiasis, or when there are obstructing ureteral stones, or when there are benign or malignant obstructions of the ureter and the kidney. I'll just briefly mention a couple other indications. One of which is when there's been an injury to the collecting system or ureter after trauma, either some kind of usually penetrating trauma or iatrogenic injuries from surgery. Stent placement, preserving antegrade flow, typically results in healing of collecting system injuries. Stents can be placed in the setting of fistula formation, but usually is palliative in the setting of malignant fistula formation to the ureter, is that those typically are not going to heal spontaneously. And then finally, stents are placed for identification of the ureter in the setting of surgical procedures, particularly gynecologic procedures. They allow the ureter to be more easily identifiable and therefore protected. But the vast majority of stents are placed for ureteral obstruction and stone management. Placement is relatively straightforward, although requires significant expertise and technique in some settings, particularly trying to traverse sometimes high-grade and tricky obstructions. But most commonly, ureteral stent placement is done in the operating room with the patient under general anesthesia. Cystoscope is placed, and cystoscopy and evaluation of the bladder performed, and then the ureteral orifice cannulated. A soft tipped wire is then placed into the ureter and then pushed up into the proximal renal collecting system, which is done under fluoroscopic evaluation typically. And once the guide wire is coiled within the proximal collecting system, the appropriately chosen catheter or stent of appropriate diameter and length is placed over the guide wire, and a pusher behind it, pushing the stent up into the proximal collecting system. And once that's confirmed, the guide wire and subsequently the pusher is retracted, leaving the stent hopefully in good position with the proximal coil within the right renal, or within the renal pelvis, and the distal aspect within the bladder. Typical stents are double pigtail configuration, proximal and distal coils to allow the catheter to maintain its position Usually there are 5 to 9 French in diameter and 20 to 30 centimeters in length, typically of some type of polyurethane construct. There's a number of there's significant research that's being done to look even now at improving stent composition, including things like creating a stent that is less likely to have calcification and bacterial deposition, stents that are peripherally softer and less irritative of the bladder and the collecting system, and even stents that are biodegradable. Just as a quick aside for the diagnostic radiologist who may not deal with catheters on a daily basis, I just have at times been consistently confused with French terminology regarding catheter size, or the French scale, appropriately originally created by a Parisian surgical instrument maker. But at the end of the day, the thing to remember is that for me, a 30 French catheter is 10 millimeters in diameter. In other words, a 3 French catheter is 1 millimeter in diameter. And that's the way I remember the size of a catheter regarding its size. It is interesting that although I'm not sure that it has any clinical relevance, but if the French scale is pretty close, the French designation is pretty close to the circumference of the catheter as well. So 30 French catheter is about 10 millimeters in diameter, but also about 30 millimeters in circumference. So just an aside for the somewhat slow-witted diagnostic radiologists who don't see these, as opposed to the IR docs, don't see these catheters on a daily basis. Okay, so let's talk about the normal position or the expected or the hoped for position of a placed ureteral stent. Well, obviously the proximal coil or pigtail should be within the renal pelvis. The distal pigtail should be not just barely into the bladder, but 4 to 5 centimeters beyond the ureteral orifice is optimal. This allows some give because the kidneys, move significantly with inhalation and exhalation. The bladder fills and empties, and the patient moves. So you don't want a catheter's distal aspect just barely into the bladder. Because of this motion, it may get retracted into the ureter. So, but on the other hand, you don't want a catheter that's so long that the distal aspect is up against the bladder wall or bladder base, creating unnecessary irritation and potential for actually migration out the urethra. So the appropriate placement of the distal coil should be within the upper quartile of the expected bladder circumference. So in the cartoon at the lower left, or at the left, you can see that if you drew a line that was through the bladder and halved it and created one quartile, you'd like the coil to be within the central portion of that quartile. Distant, 4 to 5 centimeters distant from the ureteral orifice, but not so long that it's going to butt against the distal bladder wall. And the KUB on your right illustrates a good or well-positioned ureteral stent. Proximal coil is coiled. That's one thing to mention, that there should be a good coiling of the catheter. And the proximal coil in the area of the expected renal pelvis, and the distal coil within the within the upper quartile of the bladder, but more towards the central portion. Common symptoms of ureteral stents are important to understand and recognize, so that sometimes when a patient presents with these symptoms into the emergency room, it doesn't necessarily make us think there has to be something, some complication. Stents tend to be irritative. They create discomfort in the bladder, in the kidney itself, so flank discomfort, but also even more so within the bladder, including just painful discomfort, but also urgency, sometimes even incontinence. They irritate the bladder lining, creating hematuria and sometimes pyuria, and they reflux. They cause the ureter to reflux. Some of the newer stents, some of the research into the newer stents have some kind of valve mechanism to try and prevent this reflux. So anyways, this sort of summarizes what the typical stent should look like, why to place them, how they're placed, what's a typical or good position for them, and then what are some of the common symptoms associated with them. This is my buddy Max. This is a 3D camera. I have no financial incentive, but this is from the Theta S series. It's a great little 3D camera. Creates not only 3D pictures, but 3D videos. This obviously is not a true 3D video or a picture where you can pan around. This is a 3D picture that's been filleted, but still creates kind of a cool picture. Anyway, so the last half of this lecture, the last third of this lecture, is related to complications that we may, as radiologists, be the first to identify and hopefully, maybe in some situations help to correct. We'll talk about malposition of stents, migration, urinary tract infections, inadequate relief of obstruction and incrustation or calcification accumulating on stents, stent fractures. The last four here are pretty straightforward, and that's that catheters may break, they may erode, they may remarkably become knotted and may be forgotten. But we'll talk about all of these. The first complication is the malpositioned stent. This is a stent that is either too short or too long, or actually is outside the urinary tract. Here is an example of a malpositioned, too short stent. So the distal coil was not, the length of the stent was such that the distal coil was pulled up into the ureter, so-called fish reeling, and becomes uncoiled. Here is a stent that is too long. The distal aspect is actually migrated into the urethra. The arrow, although it's hard to see because of the Foley catheter, but the distal aspect of the stent is actually within the urethra. And even if there isn't urethral migration, the stent would be unduly irritative of the bladder. One thing that's recently been developed to try and um, reduce the incidence of malposition stents is creating a multi-length stent. I will tell you, so that there are multiple ways to try and determine, what's the appropriate length stent. Usually it's done at the time of stent placement and using the guide wire to basically calculate or show the appropriate length catheter, although it can be done with things like patient's height and other mechanisms. But there's still some difficulty in choosing the correct stent length. A multi-length stent is one in which the coil is self-adjusting to correct for the appropriate length. In other words, it coils more in a setting of a shorter ureter than expected, and uncoils more in the longer ureter. In both cases, hopefully it's self-adjusting to create an appropriate length stent and eliminate too long and too short stents from malposition. Finally, one other type of malposition that requires some consideration is malposition of a stent outside the urinary tract. The guide wire is placed, and sometimes it's difficult to traverse a tightly obstructing stone or malignant obstruction of the ureter. That guide wire may penetrate the ureter or the collecting system and pass outside the urinary tract, and then the catheter placed over the guide wire may ultimately end up being outside the collecting system as well. This is usually recognized at the time of placement, as I think today. And if a urologist is out there and could comment, most stents are injected at the time of placement to assure that they're within the collecting system, but nevertheless they occasionally may not be identified as being outside the collecting system. And on your left, this is a case where the wire and subsequently the stent passed outside the renal calyx and through the kidney into the perinephric space. In this case on your right shows the left-hand image of a stent. The wire was initially attempted to traverse the small stone noted by the black arrow, passed outside the ureter, although in close proximity the stent was placed, and looks like it's probably in pretty good position, but I'll tell you the stent should be not any separation from the stone itself. It should be sitting right adjacent to it or overlying it. And the subsequent repositioned, the catheter was repositioned, and the image shows the stent. The stone is migrated a little more distally, but the stent and stone are immediately adjacent or overlying each other. So malposition, including too short or too long of stents, as well as stents, wires and stents that are ultimately outside the urinary tract, are important complications for the radiologist to identify. Migration is somewhat different in that the stent was initially in an appropriate length and position, but subsequently migrated out of good position. Again, the kidneys move with inhalation and exhalation, the body moves, the bladder empties, a lot of motion there that creates a situation where the stents, despite the proximal and distal constraining coils, may move. Here's an example of the more common on your left type of migration, which is distal. Because of peristalsis and other factors, the body wants to get rid of the stent, and so it typically is pushed distally, and in this case coiled in the bladder. It can occasionally migrate proximally. The stent can migrate proximally, so-called fish reeling, as the image on your right shows. So a couple examples of migration. Stents are almost all colonized when they're in place, unfortunately, and frequently these patients have persistent pyuria and urinary tract infections. But occasionally these urinary tract infections can become more significant, as in this case, where there's the development of pyelonephritis in a small capsular microabscess. This is important to be suspicious of, because these patients clinically come in with flank typically, as we discussed, an ordinary stent has flank discomfort. May have pyuria in the urine, white cells in the urine, may have a little hematuria, so they're typically kind of mimics a urinary tract infection. So if in a typical non-contrast CT, be careful to look for potential signs of more significant infection, including perinephric stranding, or in this case, the upper left-hand image where there's a hint of subcapsular fluid, and then you may recommend a post-contrast study. This is a complex component of stent issues regarding stent, and that's whether the stent is actually functioning or is occluded and not functioning. And radiologists are often involved with evaluation of whether these stents have become obstructed or are not functioning well, and this can be difficult clinically, because the symptoms of stent obstruction and malfunction overlap those of a typical stent, including flank pain. But we are asked not infrequently to evaluate these patients to assure that there is stent patency and function. There are two main ways of two primary ways for evaluation of stent obstruction. One is using ultrasound, and the other is a cystogram or lupogram. First, an ultrasound can be used, and one way is to look for increasing hydronephrosis. I will just give a cautionary caveat that without old films, including a series of old films, one image of the kidney in the setting of a stent in place can be difficult to evaluate. There can, in other words, and that wasn't well stated, sorry. In other words, there can be significant hydronephrosis without stent obstruction, particularly in the setting of ileoconduit. And even the opposite holds true. There can be a decompressed, non-hydronephrotic kidney that is actually obstructed, depending upon the length of time of the obstruction. So be careful being overly sensitive regarding hydronephrosis, really, unless you have a series of old studies that you're real comfortable with what is the baseline appearance of the collecting system. This is the appearance of the collecting system is difficult to hang your hat on. One thing that can be done, however, is evaluation of the distal aspect of the stent. Sometimes that's not always performed. The identification of ureteral jet using Doppler and color flow is useful in that it really suggests that the stent is patent. In my experience, the absence of a of ureteral jet emanating from the distal stent is less helpful because patent stents may not demonstrate it. But the identification of a ureteral jet, I think, is pretty accurate in stating that the stent is patent and functioning. The other method, maybe in my hands, a more preferable a method because of its binary diagnostic scenario, is that of a cystogram or leukogram. Basically, you perform, in this case, a cystogram, assuring that there's significant distension of the bladder, and simply you evaluate whether there's accumulation of contrast within the proximal collecting system. Accumulation of contrast means the state as the stent is functioning and patent, the absence of which suggests the stent is not, and it's typically exchanged by the urologist. Some of my residents try and look at the stent itself, trying to identify contrast throughout the length of the stent. That's not the role of this. That's not the that's not practical in my experience. It's quite simply, is there contrast opacifying the proximal collecting system or not? Incrustation is simply the accumulation of calcification along a stent. It's an ordinary or typical process. If the stent is in place for too long, it doesn't suggest an underlying abnormality necessarily, but can be problematic in that the calcifications create anitis for recurrent urinary tract infections, can create difficulties in exchanging and removing the stents, and can create a fragile stent prone to fracture. Here's an example of proximal incrustation around the coil and proximal stent. Once the stent's removed, there's a remaining cast of calcifications that probably needs to be managed, usually with lithotripsy, as these casts are superinfected and will create not only a potential for obstruction, but persistent urinary tract infections. Here's a distal coil incrustation. The coiled part of the catheters tend to be more prone to incrustation than the more central straight portion of the stents. But in some cases, the entire stent can be encrusted, as in this case. Sometimes the vast majority of incrustation, the calcification is of a struvite composition, and consequently can be relatively lucent and difficult to identify. So taking a close magnified view of the appearance adjacent to the stent is important in its identification. Here's a case of obviously intense incrustation resulting in need for surgery. One of the worst or most feared complication of stents is that they erode through the ureteral wall and into the adjacent structures, and at the level of the iliac crest or iliac crossing, that adjacent structure can be the iliac vessels, and thus you can have the resulting iliac ureteral fistula. This can create massive life-threatening hematuria, and can be, an emergent situation. So something to look for. It's most commonly in the setting of post-radiation therapy and malignancy that this occurs. Stents can break, especially when encrusted. Less common nowadays. And then finally, stents can be forgotten. The patient had a stone obstructing, the stent was placed, the stone passed or whatever, and they never went back to the doctor, but show up 20 years later for the evaluation of either urinary tract symptoms or something else. Typically what happens in this setting is there's significant incrustation and probably distal migration. The catheter usually passes in this setting into the bladder and then becomes significantly encrusted. Sometimes this can mimic just a large bladder calculus. It has this sort of spaghetti appearance, which may be suggestive. Okay, so that's it. So this was Noon Conference, May 3rd, 2017, University of Tennessee School of Medicine, Department of Radiology. We talked about typical ureteral stents and those complications of stents. If you'd like to leave a comment or a question below, I'd appreciate it, and we'll try and get back to you. Look forward to further lectures to be posted this site. Thanks a lot.